Congratulations to making it to week 4. We have already gone through mood disorders, which included depressive disorders and bipolar and related disorders. We are now in week 4, talking about anxiety disorders and obsessive compulsive and related conditions. I will probably repeat this more than once, but the DSM is a dense book. And each grouping of disorders has a number of disorders within it, the subtypes. The likelihood that we're going to get through all of the disorders is going to be limited for some of these groupings. What I will focus on are the issues that I believe that you will most likely see early in your practice. That means that there are going to be a number of issues, or maybe just a few issues, that we won't be able to discuss here, but I strongly urge that you thoroughly review your DSM, your textbook, learn what is not covered in these video lectures. The lack of inclusion here does not in any way equate to a lack of importance, but again, because of time, I've given thought to what you're most likely to face as an early clinician and focused on that. When considering resources for anxiety and depression, the Anxiety and Depression Association, which is ADAA, the Anxiety and Depression Association should be top of the list. Not only do they offer resources for providers in the way of articles or continuing education and conferences, they also offer an abundance of resources for clients. This is a screenshot of the site's homepage. As I mentioned, and you can see in the top right-hand tabs, attention is given to offering resources to the general public as well as to professionals. And the site assists with offering language that clients can use to understand the conditions and issues that they deal with, as well as issues of the day. If you notice, for example, this particular blog post, it offers direction on processing world events that are occurring. So it has real-time resource about the things that bring anxiety to individuals that help to create circumstances for depression. I find this site to be useful because the resources are so readily available, and I can send clients to this site and they can find it to be useful as well. So I know we've already talked about depressive disorders. This is a resource for that. Now we're going into anxiety disorders, and it can be a resource for that as well. So let's open up our minds to learn about anxiety and what it means clinically. So, a general overview of anxiety disorders according to the DSM. Of the issues in the DSM, anxiety disorders constitute the most common of all the issues. I know we sometimes think that depressive disorders are probably the most common, but anxiety disorders are among the most common of all the disorders that we see. I believe that this is due in part to the fact that anxiety is both a normal and a natural response to danger and risk. It alerts us to dangers, it prepares us for danger to come, it enhances performance, but it's also the thing that, depending on how it is experienced, can be traumatizing, right? And can be disabling because the symptoms are real. The anxiety symptoms that are felt are real. The good news is that anxiety disorders are among the most treatable, even when we don't use medication. A lot of people like to turn to pharmacology, anxiety conditions are treatable without that. I know for clients this can be hard to accept because immediate relief is really what they're wanting, but non-pharmacological treatments can be effective. They just take time and effort, but they get at the heart of the matter, the underlying issues that support the presence of the anxiety. So when clients come to me and there is recognition that an anxiety condition is present, I lead with hope. This is treatable even without medication. Let's understand how anxiety generates in the body. And the hope is that this will help to underscore the realness, because this isn't just something that people can indicate that they feel. These are real processes that are going on in the brain and the body, except they are sometimes triggering at times when they aren't necessarily needed. But when the body and the brain get some sort of signal or information that there's the potential for risk or danger, that information gets interpreted in the midbrain. And it's in the midbrain that we have our limbic system, which is really the source of our more primitive reactions. The limbic system houses the amygdala. So what does the amygdala do? The amygdala translates incoming information and it gives it value. So when the amygdala assesses, recognizes the presence of a threat, it sounds warning and alarm bells and really activates the body. This ringing of the bell initiates our fight, flight, and freeze response. Once this happens, higher order processing gives way to primitive responding, which suggests that the organism, the body, the person, should be protected at all costs. It's worth noting that the amygdala can misread a signal and it can indicate danger when none is present. It can sound the alarm without provocation. It is usually this latter circumstance that creates the worry because the reason for the angst is unclear, it's unexplained, it's not obvious. So the question for many clients becomes, or many sufferers becomes, is something wrong with me? Am I having a heart attack? When we think back to that list of symptoms, am I having a heart attack? Am I going to die? Without a reasonable explanation, unhealthy responses result to the constellation of symptoms, and fear and panic set in. Of course, this is understandable when the person is experiencing actual heart racing and dry mouth and dizziness and sweating and palpitation, right? So it makes sense that panic would set in and the person would imagine that there is a danger outside of themselves that they need to protect against and potentially avoid. So, what are the anxiety conditions? They include separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder or social phobia, panic disorder, agoraphobia, general anxiety disorder. There is also anxiety due to another medical condition, other unspecified disorder, and unspecified anxiety disorder. I've highlighted just a few of the conditions. Those are the ones that we're going to expand upon, but I will offer a a brief overview of the others. Separation anxiety disorder is akin to stranger danger. All children should go through a phase of development where they are afraid of familiar others. This is protective. However, when that fear of separation becomes prolonged beyond the developmental period and expectation, then it may be disordered, particularly if the distress upon separation includes excessive crying and protesting, a difficulty sleeping alone. There may be concerns about something happening to the caregiver if it leads to aches and pains or trouble separating for school. Okay? At that point, these symptoms create a functional impairment where the child isn't able to do the things that children should do, like interact with other kids, attend school, and so forth. Selective mutism. Selective mutism is really, as the name suggests, it is an anxiety response of silence, however, selectively. What this means is that a child might be talkative in one location, but choose not to utter a word in another location. But the lack of speech is happening when the child is capable of speech. The lack of speaking in and of itself creates the functional impairment. If we are expecting a child to attend school and to communicate with their teachers and that doesn't happen, functional impairment. You are probably familiar with specific phobias. These would include the various fears like the fear of spiders or heights or claustrophobia. Remember that with a specific phobia, the fear is excessive and it's disproportional to the circumstance, and it causes a disruption in functional capacity. Finally and briefly, agoraphobia. Agoraphobia is technically fear of the marketplace. It represents an intense uneasiness to leave home or some other safe space because of an intense fear of being overwhelmed with anxiety without a clear escape. In response to that fear, the person begins to restrict their environment only to the places where anxiety can be best managed and where escape is not needed. For many, the home or the bedroom is that place because escape isn't desired. It is already assessed as being safe. This is the brief overview for the conditions that have not been asterisked. I will now go into more detail on the other conditions. Social phobia, we're going to begin with that one. Before I give you the symptoms, the diagnostic criteria for social anxiety disorder, I just want to lead with the co-occurring disorder here. We've talked about co-occurring versus differential diagnoses. Social phobia could be comorbid with autism spectrum disorders because of the social component. So once we get to autism spectrum disorders, you will hear the additional features of that condition that are not present for a social phobia, but I want to put that out here at the beginning because there is that social engagement aspect of a social phobia that can sometimes be confused with the social interaction aspects of an autism spectrum disorder. So you want to dig when you're doing your intake to make sure that you're fleshing out that this is indeed just social phobia and not the social component that is a part of an autism spectrum disorder. So what does a social anxiety disorder look like? It is a significant fear around social situations where there is the potential for being scrutinized or negatively evaluated by other people. The fear of a negative appraisal is strong and usually produces fear or panic about that social situation. In response, that circumstance then is usually avoided. It has to be noted, though, that the fear is out of proportion to the presumed threat that the situation would create. That is the nature of an anxiety disorder. The fear doesn't match the circumstance. Nonetheless, the reaction of fear or avoidance must have lasted for at least 6 months and create the functional impairment that most disorders have to have present. Importantly, we recognize, or we reconcile rather, that there is no medical or physical reason for the avoidance, nor the impact of substances could explain the fear. This doesn't mean that that a person does not have a medical condition. It just means that, or even a substance addiction, it just means that the fear reaction is not a function of that medical condition. The fear is not a function of the impacts of the substance. Now, try to give thought in your mind to the types of individuals who may suffer with a social phobia. Oftentimes, our minds go to people who are shy or introverted. And a person who is shy or introverted isn't necessarily meeting criteria for a social phobia as is laid out in the DSM. That person could just be quiet. A social phobia has the underlying motivation concern about negative evaluation. People who are just reserved or shy aren't necessarily reserved or shy because they think somebody's going to negatively evaluate them. A person with a social anxiety disorder, that is what they think, and that is what creates the avoidance. It's important to remember that this disorder presents in social circumstances or circumstances where there's going to be evaluation. So, apart from social situations, the anxiety and the fear may be absent. Moving on to panic disorder. For starters, let's discuss the words panic and anxiety, as some say panic attacks while others say anxiety attack. Often they are used interchangeably. Some like to suggest that referencing the experience as anxiety denotes lesser intensity than referencing the experience as panic. But suffice it to say, the two words are essentially the same. For a panic disorder to exist, there must be recurrent and unexpected attacks of anxiety. Why unexpected? Well, as a clinician, we would not render a panic disorder diagnosis for a person who, while camping, was startled by a bear and produced this constellation of symptoms. However, when an individual repeatedly and suddenly surges with fear without cause, a panic disorder is considered. The panic attack or the surge of fear reaches a peak in a short amount of time and includes at least 4 of the following: a racing heart, sweating, shaking, shortness of breath, a choking feeling, chest pains, nausea or stomach upset, dizziness, numbness, feelings of unreality, a fear of dying, or even a fear of losing control. Once a panic attack has happened, for a panic disorder, for the next month, one or both of the following have to occur. There's either a concern for a recurring panic attack or panic attacks, or there is a behavior change or avoidance as a result of having had the panic attack. Now, it is the case that while panic attacks are unexpected, they can be triggered by something real or imagined or even anticipated, because whatever that was considered to be life-threatening. But what maintains the panic disorder is one of those two circumstances. The differential diagnoses for panic include ensuring that another mental disorder does not better explain the symptoms. If a person has come into contact with a spider, and we know that they have a fear of spiders, but they panic at seeing the spider, we wouldn't give a panic disorder, we would give a specific phobia, right? If the person had to do public speaking and became overwhelmed and panicked, again, we wouldn't give a panic disorder as the diagnosis. We would go with a social phobia. So we have to be mindful of differential diagnoses and rule out any medical conditions, because some of those, like low blood sugar, could mimic panic symptomatology. Panic disorder is going to affect about 2 to 3% of the adult and adolescent populations. We are not going to see as many anxiety attacks or panic disorder among Latinos or African Americans or Asians or Caribbean blacks. But we are going to see prevalence rates increasing for adolescents, particularly females, and then there being a decline in older adults. If panic disorder is untreated, it can become chronic and debilitating, because if the panic is around uncertain conditions, everything could be a potential cause. Therefore, every environment could be one that the person restricts from. As you are probably coming to understand, anxiety is about giving a response of fear or worry that is out of proportion. Generalized anxiety disorder is that same thing also. It is persistent and excessive worry, but around a number of different things. So there is difficulty controlling that worry, meaning the person has the worry more days than they don't, and it's lasting for at least 6 months with 3 or more of the following. And you can see those here: the nervousness or the rapid breathing or feeling weak or tired or concentration difficulties and the such. A generalized anxiety disorder says the person worries about lots of things and they can't stop worrying about lots of things, even though worrying about those things is unwarranted or not merited. Generalized anxiety disorder affects about 3% of the population. Women are going to be twice as likely to be impacted over against men. There is a gradual onset of a generalized anxiety disorder compared to a panic disorder, which has a sudden onset. The highest presentation of a generalized anxiety disorder is going to fall between childhood and middle age, and family background and context are significant in the development of a general worry. Life experiences lead to a generalized anxiety disorder, and it's usually managed by avoidance. And it's the avoidance of the worry-provoking things. We're going to avoid travel because what if this thing happens? In a lot of ways, generalized anxiety disorder is the what if. It's the anticipatory anxiety condition, right? So if we do this, this thing could happen. There's the constant worry that a something could happen, and it leads to the physiological response and reaction that was presented in the previous slide. Hopefully you are already starting to give thought to the social impacts of anxiety conditions and how agoraphobia, for example, could wreak havoc on a relationship, a husband with a wife, or a parent with a child. I'm going to show a video, not necessarily about a social impact directly, but to give you some understanding from a sufferer's voice about living with anxiety day to day. And then thereafter, we'll talk about the social impacts. I've included this video here with a link. I'm not going to play it in this particular video lecture because I don't think that it will play through, but I'm hopeful that when you go to the slides separately, you will take opportunity to hear Zach's voice as he talks about living with anxiety. I do want to include the disclaimer that it talks about a specific treatment facility. I'm in no way supporting that particular treatment, but I like how this video not only gives you the experience of anxiety from his perspective, it also gives you some bit of perspective from the mom viewing her child who is anxious and her desperation for treatment. But it also, at the end, starts to talk about what the treatment could look like. That's a little bit beyond what we're doing in this class, but I thought was helpful nonetheless. So please take a moment to go back and view the video on your own time. While there is never a good time for an anxiety disorder, when we're thinking about panic disorder in particular, it tends to strike just during the productive years. So when the individual is attempting to create their adult lives, there is this intrusion of anxiety that keeps them from being financially independent, and it encourages a financial dependence on other people. The suffering generally is tremendous, disruptive, not just of the moment, but of the future. And it's disruptive in an unexpected way. There is constant concern because the panic has come on suddenly and unexpectedly for what caused it. It's not clear if it was something internal or something external, so we can understand how the entire world becomes a point of fear and how avoidance and restriction become the answer for that. Hopefully by now, it goes without saying that anxiety is definitely a relational disorder. It has the ability to impact friendships, relationships, schooling, occupation, to create marital deterioration, right? It impacts families because it draws them in when the person is too afraid to live out their lives. So, when we're thinking about doing treatment for anxiety conditions, we absolutely must have family members present because they are already impacted, either because they are trying to enable the sufferer because they have a hard time watching them suffer, or they choose not to help and that creates distance, right? When we think about marriages in particular, while we might imagine that anxiety would create a disruption in a marital dyad, sometimes it is the opposite. When a person who has been fully reliant on a partner becomes well, that places a chasm in the usual relationship. And that creates instability. So the getting well for a panic condition creates instability. The last thing that I want to leave us with is parenting. We know that there is an increased likelihood of having an anxiety disorder if a parent has an anxiety disorder. Children can be taught by anxious parents to view the world anxiously. The world becomes projected as this fearful place, which means the amygdala has to constantly see the need for protection. Anxiety is a family affair when it comes to treatment. We can't attend to one person in the family unit without also bringing in the others.